out over Jet. This song could be about what you're searching for. You're looking all over town, and I'm knocking on your front door. This could be, this could be, it could be about us. This could be all about us. This could be, but it ain't gonna be about us. This could be. This song could be about our wedding day, but you just had to go to see him. That decision left me in dismay. This song should be about when I got your call saying you weren't ready for marriage, that you couldn't commit at all. This song should be about our happy years. Instead it's about when he hurt you, I was there to dry your tears. This song could be about how I'm not around. See, I came to my senses, putting my feet back on the ground. This could be, it could be about us. This could be all about us. Yeah, but it ain't gonna be about us.
Hi, this is Steph, and you're listening to WNHHLP 103.5 FM, broadcasting from New Haven, Connecticut.
Hello?
I had to call him back.
Okay. I'm going to put you on hold, and she should be with you in the next 3 minutes.
Okay.
In the very worst state.
Okay. Hold on.
But I didn't find anything specific.
Our wedding day, but you just had to go to see him. That decision left me in dismay.
Good morning. You're listening to WNHHLP 103.5 FM, New Haven's home for community radio. I'm Mubarakah Ibrahim, and this is Mornings with Mubarakah, where we talk about national issues from a local level through a lens of diversity. You're listening to WNHHLP 103.5 FM, broadcasting live from downtown New Haven. We are streaming live on TuneIn Radio and newhavenindependent.org. We're also streaming live on Facebook. You can find us on the New Haven Independent Facebook page, as well as the Fit Muslimah Facebook page. So we are here on another wonderful Wednesday morning, and it has finally started to warm up slightly, warm up just a little bit. It was really cold for a couple of days, and I don't know why. Spring just seems like it's not fighting hard enough. It's not. Come on, spring. We're rooting for you. You
Still
have to
wearing
come
my
out.
jacket. I
I
still have
know.
my jacket, Mubarakah.
It's ridiculous because it's
Yeah.
the 18th of April. Oh my goodness. But today we have with us two women to talk about a very important topic. I would like to welcome back to the show, Khadija Gurna. Welcome back. Thank you for joining me.
Thank you. It's always a pleasure, Mubarakah. Thank you for having me.
And on the phone, we have a Connecticut resident, but she is not here today. So she's joining us on the phone, Dr. Abigail Maxwell. Welcome, Abigail, and thank you for joining us.
Thank you for the invitation, Mubarakah.
Awesome. So today we are talking about the American health crisis of Black maternal health. And I'm going to tell you a little bit about both of our guests. So Abigail is a board-certified pediatrician who subspecializes in neonatology. She completed her pediatric residency training at UMDNJ in Newark, New Jersey, and her neonatology fellowship training at Maria Ferrari Children's Hospital at Westchester Medical Center, where she helped develop their first milk bank. She is the owner of Anacom Inc. and works nationally in level 2 to 4 NICU centers. She is particularly interested in urban centers where she advocates for mothers, especially Black moms. She recognizes the inherent racial bias many healthcare providers have towards families of African descent and uses these work opportunities to address these biases and also empower the families of her patients. She is a champion for breastfeeding as an integral part of infant health and has successfully engaged in many minority mothers of preterm babies to breastfeed. So she, in addition, she is a mom herself of 4, the wife, and she is a wife of her husband, Kerry Maxwell, and she lives here in Connecticut. And Khadija has been on our show a couple of times, and we are excited to have Khadija back as a regular guest now. I'm going to call you a regular guest. I'm going to own you.
Thank you. Thank you so much.
Khadija Gurna is an advocate and a mother. She works as a campaign director on faith-based outreach and immigration advocacy at Moms Rising. Khadija has worked on engaging government and nonprofit sectors to achieve racial justice and health outcomes. She was awarded a Champion of Change Award from the Obama White House for her work engaging faith communities on healthcare access. She is a master in public health from Yale School of Public Health and over 15 years of experience in community outreach. So when I decided I wanted to do a show on Black maternal health, of course, these are the first 2 women that came to mind, and they were both so gracious to talk to us about this conversation. So Black maternal health has, I think, particularly in the last, say, 3-4 years, since we have had a rise of the Black Lives Matter movement in particular, I think has taken a little bit more of a focus. I think in the public health arena, it has always been known and been a concern for a while, but a little bit more of it becoming more public knowledge that this is actually a crisis here in America. We live in a country that is one of the richest countries on earth. We spend more per capita on healthcare for individuals in the United States than any other nation in the world. But yet Black mothers are dying 4 times that of their white counterparts. So this is not just a crisis of health, it's actually also a crisis of race. And so today our conversation is going to surround, why do we have this crisis? What exactly is its impact on our society, and how did we get here, right? So and the interesting thing about this conversation, what I thought in the beginning when I was thinking about how do we approach this, is it's not like okay, this is 2018. It is not 1818 where Black women did not have access or did not have the same health providers as white women. It's not like we are in segregated hospitals or in segregated, Black women can't go to certain doctors. More or less, even you have access to the same. So why are Black women dying much more?
So that's interesting that you have that comparison, because New York Times just had a very profound article, and it looked at this idea. What are the racial disparities during slavery, like say for 1850 is the example they gave, and the racial disparities now. So infant mortality in 1850 for Black women, so Black infant mortality was 340 deaths per 1,000 live births. And for white infants, it was 217 deaths per 1,000 births. So there was clearly a disparity, and people were concerned about it. But today, the difference is, so both rates have dropped dramatically, right? Mm. But the difference has actually grown. So at this moment, the infant mortality rate for Black babies is 11.3, so 11.3 deaths per 1,000 live births. And for white babies is 4.9 per 1,000 births. So that means a Black child is, a white child is twice as likely to reach 1 year old than a Black child born today. Mm. So part of that, it's an interesting idea that you brought up. Do Black women actually have the same kind of access to care that white women do? And I think that's a topic that in the public health world has been looked at a lot, right? And I do want to talk about that. But as people have examined what kind of access to healthcare Black women have, what kind of access to white women, access to healthcare white women have, and there are clear racial disparities. So one of the examples I will give you that is an example that many people know of is, we discussed briefly yesterday Serena Williams, and she spoke about her birth, right? So she had access to incredible healthcare, some of the best healthcare you can get. But her experience as a Black woman found her that she was left wanting. So she was actually postpartum, she had a C-section. She was experiencing trouble breathing. And in that situation after C-section, that's something that should be watched for. But she wasn't watched, and she had a near-death experience. Like 65,000 women nationally have a near-death experience after giving birth. Mm. And Serena Williams, one of the most powerful Black women in this country, was one of those. Mm. So even if you have access, I would argue that even if you have access to the same hospitals, the same doctors, the same nurses, the experience that Black women are having is very different to the experience that white women are having, going through the same services, even when they have access to the same services, because there's a disparity there, right? And one of the reasons is, and it's been studied a lot, is there's strong stereotypes and misconceptions that even healthcare workers who are well educated, so for example doctors, have about Black women, that they can tolerate higher pain, that they can that the pain. So for example, Serena Williams was very clearly saying she was experiencing distress, but that distress was dismissed, and that's not a unique experience. So let's bring that. Sure. That's a good point. Let's bring Abigail in on that point. So Abigail, you are a doctor that is active in the medical field, and you deal every day in these arenas in hospitals. You deal with children who are in a health crisis and families. Do you see a difference in how doctors respond to Black families versus families of other races?
Yes, definitely I do. So I start off with, talking with moms before they actually deliver, doing the neonatology consultation, meeting the families. Then I have those who, deliver and I meet them then, and then others who are transferred in. But along the way, there definitely are, different points in which healthcare providers have an opportunity to connect with the mothers. I have had a chance to actually observe other providers talking with parents and then having parents talk to me about their experience with providers. And definitely there is a bias. Sometimes it is conscious, other times it is unconscious. It's conscious in how the providers react to the families. But the thing about racism is that unless you experience it or unless there's documentation of it or, many articles that come out, it's oftentimes hard to tease out and to explain to others. And I'm really glad that more articles are coming out talking about it, and even this last New York Times article talking about experiences that women have in the healthcare field. So yes, I definitely agree. Access to healthcare is one problem. However, even for women who do have access, for example, I did training in Newark, New Jersey, and a lot of the mothers had Medicaid insurance, and they would call the clinics for an appointment for the first OB, and sometimes it wouldn't be seen for 2, even 3 months because the clinic would only see 6 patients with Medicaid in a given day, 2 or 3 days a week. Wow. So these women have insurance, but they don't have the access. And, you can say is a clinic really busy? No, it's just a clinic has chosen not to take, a complete slate of Medicaid patients.
Mm-hmm. So one of the interesting things that, people, I know for me, until I found out this information, I had kind of like this curiosity, and this is probably just a side note to add to the conversation, is one of the reasons why there is a clear preference in the medical offices and hospitals for people with insurance, HMOs versus Medicaid, is the government does not reimburse doctors and medical providers 100% when a patient has Medicaid. So if for every dollar they only get, I believe the last amount that I heard was like 72 cents for every dollar. So if they do a procedure that is $100, someone on Medicaid to someone who's on Medicaid, they're only actually going to get $73 for that 100. And so they try to compensate for the additional with patients who have HMOs. And understanding that actually brings lots of questions in mind into policy and things like that, which is probably a whole nother conversation. So I just thought that I make that side note because often I think before I knew that there was a clear financial difference. Like because in the end, they still got to get paid, right? Why doctors treated people with Medicaid or Medicare differently. And it really, in lots of instances, comes down to the money. And that is a policy issue more than anything. When we talk about...
Yes, that's definitely true.
When we talk about... the just having access, it's not just a poverty issue. So it's not just about poor women, because even with women who, as you mentioned, Serena Williams, even with women who clearly does not fall in that category, when they look at your peers, which is, I was watching a documentary earlier, and they mentioned that the health outcome for a Black woman with an advanced education is the same as a white woman who does not have a high school diploma.
Yes. So this is a very important point, that it's not just about access. So as you mentioned, that even educated Black women, so they've studied this intensively, right? And they've looked at, and the interesting thing is that it's not the case that poorer and less educated women have worse health outcomes, worse infant and maternal health outcomes. It's about race, that a Black educated woman still has a higher risk of maternal mortality than a white woman who doesn't have the same educational level, right? And the interesting thing for me as an immigrant, as a Black immigrant, is that they looked at when you have Black immigrants, so immigrants from Africa, immigrants from the Caribbean, actually have similar maternal outcomes to white women, but their children their children have worse health outcomes. So this is not. So
that's really interesting.
Yes.
So why do they think that
Yes.
that's so? I just want to, I need you to repeat that.
Yes.
Because I think that is a really profound point.
Yeah. So Black immigrants from Africa, immigrants from the Caribbean, actually have similar outcomes, maternal and infant birth outcomes, as white women in America, but their children don't. Their children, so second, third generation immigrants, Black immigrants, actually have worse health outcomes than their white peers. So this maternal mortality crisis isn't about race. It's how race is experienced in America. It's about how you experience race in America as a Black woman. Something about what Black women are experiencing in America is what is causing this these horrible maternal and infant mortality rates, these racial disparities. It's how we're experiencing it. So part of and there's, when people discovered this, it was shocking because people assumed that it was to do with poverty, that people confound poverty and race. But race and poverty are actually two distinct things, especially when we're talking about maternal and infant health.
So that's what's interesting, or what pops out to me about that particular thing, again, just bringing kind of like this asterisk to listeners, is that it's, even though how doctors react or treat you or have unconscious bias is a part of it, but that's not the whole story. It's not just the doctor's fault. It starts before that.
Yes.
So one of the points that I was reading said that Black women also having not just less access to health care, but not being insured, and so they could have pre-existing conditions that are just exacerbated by pregnancy. So you have high blood pressure, but you have no idea you have high blood pressure because you don't have health insurance, right? And so we have at least a system, I know in Connecticut, where a pregnant woman can get Husky, but before you're pregnant, you don't have Husky. So if you are, okay, now I'm pregnant and I'm going to the doctor, the pregnancy just exacerbates the things that were wrong with me that I didn't even know about before because I haven't been to a doctor in 5 years.
So I'm going to pick up this thread, and I'd also like to turn it over to Dr. Abigail in a minute to explain this in more detail, but I'm going to pick up that thread. So the things that are pre-existing within you determines your health outcomes, right? And so what I'm saying and what research is showing is that how you experience racism is a pre-existing condition, influences how your body is responding to racism, has an effect on your maternal health and has an effect on your child's health. And Dr. Abigail, as a doctor, I'd love for you to take over and explore this a little bit more.
Do you want to chime on that?
So one researcher that I read about in the same article, Dr. Arlene Geronimus, came up with this theory of weathering, which explains the toxic effect that stress has on the body, and saying this stress, deteriorates the body. So this is before a woman even becomes pregnant. She's living in a state, in a country in which there is systemic racism, and she encounters that in many different forms. And then she, becomes pregnant. So the baby's coming into an environment that the body's already stressed. Then on top of that, there are pregnancy-related stressors that occur too as well. So then what leads to these, babies being born early? Risk factors for prematurity. Definitely poverty is one. Access to healthcare, as we mentioned, limited access, systemic racism, and stress. So underneath the category of stress, there are also microaggressions that women come across within the healthcare field, within a hospital, or even after that, whether that's being ignored when they're giving, explaining what's wrong with their bodies, One thing that we're taught in medical school is to listen to your patient. The patient will often tell you what's wrong with them, will help you with diagnosing them. But oftentimes we come in a paternalistic, frame of mind and say, this is what's wrong with you. You do this, go home and come back in 1 or 2 weeks. But that actually, those microaggressions actually have a physical impact on the pregnancy, on the woman too as well. So that when we're looking at neonatal mortality rates, the different factors that go into that, including birth defects, preterm births, sudden infant death syndrome, and the maternal pregnancy complications. With preterm birth, we know that Black women have the highest rate of preterm births and low birth weight. So we have, different factors at play that then lead to these outcomes. So as, I think we pretty much can agree, addressing poverty won't fix it. I think the major thing is addressing racism, and how do we address that individually and as a system. I don't have any answers for as a system, but in terms of individually, what I do when I'm at work is that if I come across a situation, for example, a nurse might be, telling me about a mother who she feels is being difficult or, demanding, and I always ask them, what do you mean? Like, tell me exactly how this mother is being difficult. Oh, they're asking a lot of questions. So I said, oh, okay, questions such as what? Questions about their baby, questions on the care, or questions about, what are the questions specifically? So then I really wanted them to, not just me to tell them they're being racist, but then to actually see through my questioning, what their implicit biases are towards this mother, which then will impact the care that they give to that baby. Mm. Another area too is that some hospitals like to have conferences with families, and those conferences will involve the families, the mother or the father, whichever support person, and then oftentimes it'll be the direct healthcare provider, the neonatologist, and the other specialties. So you're walking into the room, and there are 3 family members, and then maybe 10 others in the healthcare field. So that dynamic of power is very skewed. So the parents come into that room feeling disempowered, number one, because they're in the minority. There are 3 people, 2 or 3 people in a group of 10 others who are more educated than them. And then oftentimes, too, if you look at the racial disparity, too, the Black parents in the room has people who are not Black. So they're feeling disempowered on 2 different levels. So what I like to do, obviously I'm a Black physician, so I connect with my parents, but I also like to have smaller meetings because I ultimately want the parents to feel empowered in the care for their baby and to speak up whenever they have concerns and to feel like they're going to be listened to.
Mm-hmm. If you're just tuning in, you're listening to WNHHLP 103.5 FM on your New Haven radio dial, streaming live from downtown New Haven. We're also streaming live on TuneIn Radio and newhavenindependent.org. You can catch the live video on the New Haven Independent Facebook page as well as the Fit Muslimah Facebook page. And we're talking to Khadija Gurna and Dr. Abigail Maxwell today about Black maternal health. Abigail, it sounds like really from your perspective, individually, I guess, pointing out without kind of totally calling somebody out of the unconscious bias, right? So a Black woman who asks a lot of questions is being difficult versus other people are just showing concern, right? Is an important part of that advocacy. We know that there is an issue. What are some of the, and both of you can chime in, what are some of the things that we need to do from a, I guess, policy or systems perspective that can help mitigate this crisis that we're in?
Well, I think what you're doing here right now is an important step, raising awareness that this is happening, right? And there is an alliance and an organization called Black Mamas Matter, and they can be found at www.blackmamasmatter.org. And so there, as we've connected on that, they have they've organized a Black Maternal Health Week, and that to raise awareness, to talk about these issues, to talk about what's being done across the country to address these issues. And on May 6th to 8th in Washington, D.C., there's going to be a rally in support of improving maternal health outcomes on Sunday, May 6th from 1 to 4. And there will be marches in different states as well, sister marches. So one thing that I've noticed from a policy perspective is that we're beginning to hear more about this in DC, right? Because even though people have been aware and are intervening on an individual level, for it to be addressed on a systemic level, it really has to float up to the level of policy and legislation, right? To make it, to have systemic, to make systemic changes. And so something that's really important that's been happening is that, for example, there was a Black Maternal Health Week resolution supported by Senator Kamala Harris and Representative Alma Adams. So you're hearing the beginnings. A resolution is a statement, but it's an official statement coming from members of Congress, right? And for a lot of the advocacy work that I do, that we work towards getting some bills at a national level and at a state level to address some of these issues, right? And
so give us an example of some of the policy changes that.
Oh, okay. So one of the things that my colleagues at Moms Rising are working on, for example, is paid family leave, right?
Mm-hmm.
Paid family leave and equal pay for women, because they've looked at research and found that just having time for a woman to recover, a lot of women don't have paid family leave. And so that means they go right back to work right after having a baby, which can complicate healing and recovery, and also cuts off the ability for you to go and have these regular check-ins to keep tabs on how you're doing with your health outcomes. So having paid family leave actually has a positive effect on maternal health and postpartum health. And so that's actually right here in Connecticut. We're working towards a paid family leave act. And so that's something that you can plug into that will have a direct impact. Having equal pay, all of these things. So people think of it, when you think of healthcare, you're thinking of access to health and so on. And that's really important. But systemic issues, because this is a systemic problem, right? Systemic issues also have a really strong and positive or negative effect on people. So having equal pay for women lowers stress, gives them better access to healthcare. So all of these things that when you empower women, you will be empowering them, you will be improving healthcare outcomes. So those are systemic. These are policy changes that are happening right here in Connecticut that people are fighting for, right? That you can take part in. But at a national level, I think that organizations such as Moms Rising and the Black Mamas Matter Alliance are pushing for policy change. But the only way that we can achieve that is people understand and acknowledge this is a problem that needs intervention and that needs policy change. So what you're doing here is critically important and is the first step towards making policy changes.
Abigail, from the medical perspective, do you see that there could be policies or practices that doctors can implement that can mitigate some of the issues around Black maternal health?
Yes, definitely. So on the ground, even going back to medical school, having more courses, more presentations, and actually, didactic lectures on racism in medicine, right? Not just from a historical perspective, but then even moving forward, like how, our current biases can impact the healthcare that we deliver with our bedside care. And then moving forward into hospitals, every year most hospitals have online training modules that everybody has to go through. And one of those modules, I really believe should be, conscious and unconscious bias and racism in medicine, so that we can, be aware of the delivery of healthcare that we're giving to our patients, and also to how our biases can impact that.
So right now, that's not a standard training for doctors.
I mean, depending on where the hospital is, like, when I went to residency in New Jersey, we did have cultural cultural lectures, but they didn't really address the racism in medicine that occurs. And it is a dynamic field that, that people are talking about it more. So there definitely is room for improvement in discussing these areas.
So I want to take the conversation a little bit further into kind of like the health outcome of these babies, the babies that are born premature, that are born to moms who have lots of complications or issues in pregnancy. What are the health outcomes of the children? So we know that we have, when we say Black maternal rates, and just correct me if I'm wrong, we're specifically talking about moms. We're talking about women who die either during childbirth or within a 2-year period after childbirth from a childbirth-related complication. Am I right with that definition?
Right.
Okay.
So you have every year 700 to 900 women die from pregnancy or child-related causes, but then 65,000 additional women have a near-death experience. So that's the numbers on exactly what you're saying. So that's the maternal mortality rate. The infant mortality rate is looking at the likelihood of a child making it to their first year. So in terms of the United States, that a baby born in Libya has a higher likelihood of making it to their first year than a Black child born in Milwaukee or Cleveland or Detroit.
Wow.
Yeah. And so we have in the United States one of the worst maternal and infant mortality rates in the world, and in the developing world, and it's worse. It's it's significantly worse for Black. It's largely that maternal mortality and infant mortality rate is largely driven by racial disparity.
Okay, so explain. So maybe you can chime in on this, Abigail. So we talked about one of the issues with women mortality rate is how they experience Blackness in the world. A 6-month-old is not experiencing Blackness in the world. Why is the infant death mortality rate for Black babies so high? What are some of the contributing factors to that?
So the factors that the mom experiences directly impact the baby, right? So inherent with racism is poverty too as well, and also back to the healthcare again. Babies who are born preterm, especially to moms who have preeclampsia, pregnancy-related complications, those babies are often smaller than babies whose moms don't have preeclampsia. And babies who are growth-restricted babies who are what we call IUGR, those babies have an increased risk of metabolic syndrome down the road. Now, that's not going to impact them in the 1-year period, but they just have a whole host of factors that their bodies make almost like a genetic remodeling in response to the stress that their mothers experience.
Mm. So the health of the mother is directly impacting the health of the baby, which gives them, but even with that, really the worst infant mortality rate in a developing world, that really kind of shocks me.
In the developed world.
Yeah, in the developed world, because,
part of that rate also includes SIDS, black babies have a higher rate of SIDS. So the infant mortality rate is, looking at birth defects, the rate of preterm births, which are higher, the rates of SIDS, which are higher in babies who are born to Black mothers.
So, but why is that? So
that's increased risk of maternal complications in pregnancy.
So what are some of the contributing factors to that? So even with a baby dying of SIDS increase in among Black babies, why is that? What is some of the I know we can't have a solution, because then we would be like, oh, they solved all the world's problems. But
Mubarakah, you can do it. I believe in you. What Dr. Abigail mentioned is that when a child is born too early or a child is born too small, lower birth weight babies and small and children who are born before they're due, all of these things, they have higher risks for this. So what she was saying is that how you come into the world, right? Your health coming into the world, your birth weight, and when you were born, right? That is going to impact how you experience your first year of life. So if babies are coming into the world smaller and with a lower birth weight, that is going to dramatically influence what their first year of life is.
Okay. So here's the question that I have. Even though there's a disparity there among white babies who are born premature, the small percentage that are born with low birth rates, do they still have a higher chance of making it past their first year than their, we'll call them, black baby counterparts? So is it the same as with the mothers? Because we know with mothers, if you look at the counterpart of them in the white community, then the mothers still fare far less. Is it the same with infant mortality rate? Abigail, would you happen to have information on that?
So sorry, could you restate your question?
When we look at white babies who are born with low birth rates, who are born premature, do black babies, we're calling them their black baby counterparts, still have a higher infant mortality rate when we look at both sets of populations that are both born low birth rate?
Yes, I don't have any numbers on me directly, but definitely, looking at especially the extreme ends of prematurity, black mothers give birth to extremely premature babies more often than white mothers do. And just that being a risk factor by itself has an increased propensity for more morbidity, such as respiratory distress, which could lead to, chronic lung disease of prematurity, eye disease of prematurity, which can lead to blindness. So the more premature that a baby is, the more morbidity that they can have, which then will increase the risk of mortality.
Mm-hmm. So I want to get a little bit into kind of like personal responsibility or personal advocacy people can do, because I always like, even when we see these problems that seem so big that we feel like, oh, there's nothing I can do as an individual, we all can do something on an individual level for ourselves, for our family, for our community. What are some of the things that people can do on an individual level to help, whether they're a family member of someone who's expecting or they're expecting themselves?
So I'm going to reclassify personal responsibility as personal empowerment.
I like that. Okay.
So it's a difficult, because that's why I defer to Dr. Abigail on a lot of these things, because we have an information asymmetry. So a woman giving birth, right? There's no way you're going to know as much as your doctor, right? You're not going to know what is a risk factor, and especially when you're giving birth, it's a very emotional time and a very difficult time. So for a woman to know how to navigate that, knowing that, so for example, knowing that you have a higher risk, for, even as an educated black woman, you have a higher risk of maternal mortality. For you to navigate that, that's a very complicated thing and hard for you as an individual to navigate, or even for your family to seek to help you navigate that, because you're never going to have as much information as your healthcare providers. So one way, on a micro level, or one way that people have been working on this is looking at working with midwives and doulas of color. So this has actually been a very effective intervention in developing countries where there's a community-based approach, where rather than a woman giving birth and depending on the OBs or so that they may not know, they will have the assistance of either a midwife who knows them, who's from the community, who's met them before, who's built a relationship with them, and will be more responsive to their needs before, during, and after birth. And a doula is somebody who can come in case people aren't familiar with a doula, is somebody who works with the woman as she gives birth in a hospital setting or, whatever setting they're in. But it's somebody who stays by you, who has experience in childbirth and so on, but is your advocate, is your support system, and it will help you navigate before, during, and after birth, right? So the midwife can actually give birth, and a doula is more of a support system as you give birth, right? So that, on a micro level, is a way of you navigating this, as a mother. As an advocate or as a mother looking to address this systemically, I mentioned earlier the work that we're doing at Moms Rising is raising awareness. So, we actually, one of the things we're doing, if you go and find us online, momsrising.org, we're collecting these stories because part of systemic change is documenting that there is a problem, right? And as Dr. Abigail pointed out earlier, racism is still a difficult conversation for us in this country. And then coming out and saying that racism is causing these mortality rates is an even more difficult conversation, right? So in order to, one of the strategies, one of the ways that my colleagues work on this is they collect stories. So we have a story collection that we can then share with lawmakers, decision makers, policy makers, to show what the experiences are of Black women going through this, So you can join us and, be part of this process. And as I mentioned earlier, if you go to, let me find the website so I don't make a mistake on this, blackmamasmatter.org, blackmamasmatter.org, for more information about a shift in culture for Black maternal health, rights, and justice. So there are powerful women across the country doing this work and looking at systemic change, and you are powerful and you can make a difference and you can engage.
Abigail, from the medical perspective, how would you recommend, what are some action steps that people can take, personal empowerment, and advocate for themselves when they are in the hospital, for themselves and for their children?
Okay, so I really believe in empowering parents. So one of my mentors in fellowship, Dr. Parviz, used to always tell parents to have a notebook. You're going to have a lot of questions that you're not going to think about when you're in the hospital or during rounds, but write those questions down and then bring those questions, right? So that's twofold. So the parents are, becoming more engaged in the process, and then they're actually coming to the hospital. Understanding that when your baby's in a NICU, it's very stressful, and then your baby could be there for 2, 3, even 6 months. So it wears on the parents, but, really empowering them. Also, too, for some parents, they still don't feel comfortable talking to the physicians or to the nurses. So identifying somebody within your sphere who can become an advocate for you, who can speak on your behalf, especially, particularly whenever you're there in the hospital. And having that person serve as a liaison between, you, the parent, and the healthcare providers. And then on the other side of the healthcare providing, the end is the physicians and the nurses. So, really encouraging us to listen to our parents, listen to the families, and, take their concerns to heart. Don't dismiss them, and really try to make a connection. So, my work is I travel to different hospitals, and I can be in a hospital for anywhere between 1 to 2 weeks. But I always make an effort to, if I don't see the parents coming to see their babies, I always make an effort to call those parents at least once or twice a week and say, I'm taking care of your baby. I haven't seen you. When are you coming to the hospital? So it's to make it so that, if their baby does end up getting sick, I don't want the parent to meet me when their baby's dying. I want them to know, Dr. Maxwell has called me, or I've met with her, and she's updated me about my baby and addressed any questions that I have. Now, there are difficult scenarios, stress comes and plays a role, and some parents do become difficult. However, if you tried your best to make a connection with those parents, then that drastically reduces the number of difficult scenarios that you can come across when dealing with families in a stressful situation.
Well, thank you guys so much. Thank you so much. This was a very enlightening conversation, to say the least. And I hope that everyone have actually learned something, even if it's just more awareness that this is certainly a crisis in America that we need to certainly approach. So thank you very much for joining us and sharing us your views, Abigail. I appreciate it. And thank you, Khadija, for coming back again.
Thank you for having these important conversations, Mubarakah.
Thank you. And if you are just tuning in, you've been listening to Mornings with Mubarakah on WNHHLP 103.5 FM every Wednesday morning at 10 a.m. And you can catch all of our shows live on TuneIn Radio or the archived on iTunes and SoundCloud. So until next week, I remind you, as I do every week, go about your week and be a voice and not an echo.